هنتكلم على urinary incontinence, and in order to understand it we have to briefly revise the anatomy of the bladder. The bladder is a hollow muscular organ normally situated behind the symphysis pubis. It is composed of a syncytium of smooth muscle fibers known as Detrusor muscle. It is covered superiorly and anteriorly by peritoneum and is connected to the proximal urethra at the bladder neck, which rests on the urogenital diaphragm. The Detrusor muscle has a rich cholinergic parasympathetic supply. Contraction of this meshwork of fiber results in simultaneously reduction of the bladder in all of its diameter and expulsion of the urine. The urethra in female is 3 to 5 centimeters in length. The epithelium of the urethra is transitional near the bladder, stratified squamous near the external opening. Beneath this thick epithelium is a rich vascular plexus, which contributes to up to a third of the urethral pressure. يعني it helps keeping the urine inside. The urethra has a minimal parasympathetic innervation in its smooth muscles. Stimulation of these sympathetic fibers produces urethral contraction via adrenergic receptors. Beta adrenergic receptors produce urethral and detrusal muscle relaxation. The urethral sphincters. The internal urethral sphincter, it's an involuntary sphincter. يعني ايه involuntary؟ يعني هو بيشتغل لوحده، محدش بيتحكم فيه. At the bladder urethral junction, a thickening of the detrusal muscle forms an involuntary sphincter اللي هو internal urethral sphincter. external urethral sphincter, it's voluntary. يعني أنا بتحكم فيه. A skeletal muscle and surrounds the urethra as it passes through the urogenital diaphragm. The urogenital diaphragm is part of the pelvic diaphragm, which is the muscular portion of the pelvic floor that provides a stable base on which the bladder, neck, and proximal urethra rest. Mechanism of continence. The intraurethral pressure at rest or with the stress of increased intra-abdominal pressure remains always higher than the intravesical pressure by the following factors. At rest, the urethral mucosal resistance, the periurethral vascular plexus pressure اللي كنا لسه بنتكلم عنه, resting intra-abdominal pressure. In cases of stress of increased intra-abdominal pressure, kinking of the urethra and contraction of the urogenital diaphragm increases the pressure in the lower urethra. Micturition. What is the mechanism of micturition? As the urine accumulates, the bladder stretches, and stretch receptors are activated in the wall of the bladder. This causes a reflex that results in relaxation of the detrusor muscle and contraction of the external urethral sphincter. When about 200 milliliters of urine has accumulated, impulses are sent to the brain and one begins to feel the urge to urinate. Activation of the micturition center in the pons signals parasympathetic neurons that stimulate contractions of the detrusal muscle and relaxation of the sphincter and escape of urine. Urinary incontinence. Urinary incontinence is the involuntary loss of urine that is objectively demonstrable and results in social and hygienic problems. Classification of urinary incontinence. Extraurethral incontinence and urethral incontinence. The extraurethral incontinence, fistula, VESICO-VAGINAL, URETERO-VAGINAL, and URETHERO-VAGINAL. يعني ايه الفرق ما بينهم؟ extraurethral incontinence معناها ان اليورين بيعدي من مكان غير اليوريثرا. في عدم تحكم في البول، لكن البول مش بيعدي عن طريق اليوريثرا، لا بيعدي من مكان تاني. urethral incontinence معناها ان اليورين بيعدي through the urethra بس مفيش امكانيه في التحكم فيه normally. Urethral incontinence, urodynamic stress incontinence, also called genuine stress incontinence. The detrusor overactivity, also called detrusal instability or urgency incontinence. Mixed type هو mixture ما بين الاثنين وده ال commonest. Overflow incontinence اللي هو retention with overflow. Urodynamic stress incontinence is genuine stress incontinence. It's an involuntary leakage of urine through the urethra when the intravesical pressure exceeds the maximal urethral pressure in absence of detrusor activity. It occurs during periods of increased intra-abdominal pressure, such as coughing, sneezing, straining, and exercise. It results from incompetent closure mechanisms at the urethra and the bladder neck. Genuine stress incontinence occurs in about 20% of females at a certain time of their life. Prevalence and severity increase with age, parity, and obesity. 5% below 45 years, 10% between 45 and 60 years, and 30% above 65 years of age. Etiology of stress incontinence: weakness of pelvic floor muscles and supports, congenital أو childbirth trauma أو postmenopausal cases, anterior vaginal wall prolapse, or chronic increase in intra-abdominal pressure such as obesity, constipation, lung disease leading to chronic cough or chronic constipation. Let's understand the pathophysiology of stress urinary incontinence. The bladder neck and the proximal urethra are normally situated in an intra-abdominal position above the pelvic floor and are supported by the pubourethral ligaments. This position allows increase in intra-abdominal pressure to be transmitted equally to the bladder and proximal urethra, as both are situated intra-abdominally, maintaining the urethral closure and continence. Damage to either the pelvic floor musculature or pubourethral ligament may result in descent of the proximal part of the urethra and bladder neck, such that they will become no longer intra-abdominal organs. This descent prevents transmission of intra-abdominal pressure to the proximal urethra, leading to an increase in the intravesical pressure over the intraurethral pressure during straining, with a consequent leakage of urine per urethra during stress. What's the clinical picture of stress incontinence? Cough stress incontinence, the cough stress test. Asking the patient to cough while the bladder is full. ما اروحش اجيب مريضه مفضيه البلادر واقول لها كف فما الاقيش leakage واقول ما عندهاش. I have to make sure that the bladder is full. Bonney's test. The patient is put in lithotomy position. The bladder neck is then elevated gently by the index and middle fingers of the examiner's hand, placed in the vagina on each side of the urethra without compressing it. يعني خلي بالي احط one finger to one side of the urethra and the other to the other side، عشان لو انا حطيتهم عند اليوريثرا ودوست انا هدوس على اليوريثرا هعمل لها obstruction، هبوظ التست. We ask the patient to cough and see whether there is leakage or not. The Q-tip test. We insert a Q-tip in the urethra. More than 30-degree mobility during straining indicates a hypermobile urethero-vesical junction. Presence of genital prolapse should be always excluded in cases of stress urinary incontinence. This is a picture demonstrating the Q-tip test. As you can see, the Q-tip test is done by application of lubricant, applying the Q-tip in the urethra and asking the lady to strain. Normally, the applicator moves not more than 15 degrees above the horizontal plane. Excessive mobility with the angle up to 50 to 70 degrees indicates detachment of the urethra from the symphysis pubis. This is also a demonstration of the Bonney's test. As you can see, the two fingers are away from the urethra so as not to cause pressure on the urethra and obstruct it during the test. Another type of incontinence is Detrusor overactivity, urge incontinence. Involuntary leakage of urine through the urethra before starting to void when the bladder is partially full. يعني هتيجي البيشنت تشتكي لك تقول لك أنا لما بكون عايزة أروح التواليت ما بلحقش أوصل، قبل ما بوصل بيكون في escape of urine. A urodynamic observation characterized by involuntary detrusor contractions during the filling phase, which may be spontaneous or provoked. The incidence. It is the second most common cause of female incontinence after urinary stress incontinence and accounts for 30 to 40% of cases of incontinence. طب ايه الانفستيجيشنز اللي ممكن نعملها cystometry to measure the intravesical pressure, midstream urine examination to exclude cystitis, cystoscopy and IVP may be needed to exclude intravesical pathology. Urodynamic studies is one of the most important tests to differentiate. These are tests which are employed to determine bladder function. They are indicated whenever multiple symptoms are present, mixed types of incontinence suspected, or where difficulties arise in differentiating urinary stress incontinence from detrusor overactivity. They include cystometry, uroflowmetry, urethral pressure profile, and direct detrusor overactivity is diagnosed if there is rise of bladder pressure during the filling phase more than 15 centimeters of water, and urinary stress incontinence is diagnosed if leakage occurs as a result of increased intra-abdominal pressure in the absence of rise in detrusor pressure. Management of urodynamic stress incontinence. Prophylactic measures. Avoid prolonged second stage of labor and minimize childbirth trauma. Pelvic floor exercises. Avoid marked obesity and overweight. Proper treatment of chronic cough and constipation, especially in postmenopausal period. Conservative measures for mild cases include pelvic floor muscle strengthening exercises, Kegels exercises, scheduled voiding, estrogen therapy, and pessary treatment to correct prolapse. Treatment of stress incontinence. Postmenopausal cases are treated by combined estrogen and androgen preparations, pelvic floor exercises as previously mentioned, Kegels exercises, alpha-adrenergic agonists as epinephrine and imipramine. Drugs increase the tone of the bladder neck, electrical stimulation therapy for pelvic floor muscles, and surgical treatment in patients fit for surgery. Surgical treatment of urinary stress incontinence, colposuspension operation, Birch colposuspension, sling procedures like TVT and TOT, Kelly's plication with anterior colporrhaphy, periurethral injection of collagen, and needle suspension. Colposuspension operations. It is an abdominal procedure in which the upper vagina at the level of the uretero-vesical junction and upper third of the urethra are plicated on each side to the iliopectineal ligament, Cooper's ligament, by 2 to 3 interrupted non-absorbable sutures. Sling procedures دول الحاجات الحديثة والموست commonly used. TVT, tension-free vaginal tape, is performed using synthetic mesh-like tape introduced vaginally on each side of the proximal urethra, passing just below it, acting as a sling. Transobturator tape, TOT, is performed using a synthetic mesh-like tape introduced also vaginally, passing from one obturator foramen to the other, piercing the obturator diaphragm and forming a sling below the proximal urethra, with the distal tape pulled out through small growing incisions at the level of the clitoris. TOT is a simpler procedure than TVT with less complications, performed with regional anesthesia as an outpatient procedure with success rates approaching TVT. Kelly's plication with anterior colporrhaphy. It is done during anterior repair, indicated when repair of cystocele is planned by anterior colporrhaphy, associated with 60 to 70% success rate, but fall to 30% after 5 years. Less morbidity than any other abdominal procedure. Periurethral injection of collagen. This is a short-term treatment, but long-term results are only 30% after 5 years. It is done in cases unfit for other surgeries. Treatment of Detrusor overactivity is done medically using anticholinergic drugs which reduce the vesical pressure and increase the bladder volume, such as oxybutynin, tolterodine, imipramine, and antidiuretic hormone as desmopressin. Definition of genito-urinary fistula. Abnormal communications between the urinary organs, such as the bladder, the ureter, or the urethra, and the genital organs, such as the uterus, cervix, and vagina. They are usually associated with continuous leakage of urine through the vagina through incontinence. The etiology of genito-urinary fistulas are usually traumatic, direct injury during pelvic surgery, crash accidents, obstetric instruments during delivery, or necrotic, ischemic necrosis occurring with obstructed labor, pelvic malignancies, and pelvic irradiation. Symptoms of vesico-vaginal fistula. It's an abnormal communication between the bladder and the vagina. There is complete urinary incontinence, partial urinary incontinence, pruritus, valvitis, cystitis, and UTI. طب ازاي في complete urinary incontinence و partial urinary incontinence؟ complete لو الفيستولا low in the bladder. لو الفيستولا lying low in the bladder بيبقى فيه complete incontinence. أي كمية بول بتتحوش في البلادر بتنزل على طول من الابنورمال opening. Partial urinary incontinence occurs in case of high bladder fistula. لأن الفيستولا high up in the bladder. فالبلادر بيملى لغاية ليفل معين وبعد كده بيبتدي لو ملى أكتر من كده جزء من اليورين بينزل عن طريق الابنورمال opening. لكن لسه في شوية يورين في اللور part of the bladder. You can voluntarily micturate them. So it's partial urinary incontinence. يعني العيانة بتvoid urine وفي نفس الوقت عندها continuous trickle of urine. Diagnosis of vesico-vaginal fistula with the patient in Sims position using Sims vaginal speculum to visualize fistula's opening and detect urine leakage from the vesico-vaginal fistula. With the patient in lithotomy position, digital palpation of the anterior vaginal wall is performed to detect the size of the vesico-vaginal fistula and surrounding scarring or fibrosis if present. طب ايه الانفستيجيشنز اللي بنعملها؟ retrograde colored dye injection into the bladder, intravenous pylography اللي هو IVP, cystoscopy and urethroscopy. What is the management of vesico-vaginal fistula? Conservative management. Necrotic fistula, silicone catheter is introduced through the urethra and left for a period of 4 to 6 weeks to divert the flow of urine away from the fistula to prevent bladder distension and allow wound healing. يعني طول ما اليورين بيعدي من الفتحة عمرها ما هتلحم. فأنا لازم أبعد اليورين عنها عشان تبتدي تقفل بلس إن البلادر ما يبقاش distended فتبقى الإدجز بتاعة الأوبننج قريبة من بعضها ففي فرصة أكتر إنها to heal. Surgical repair is usually postponed 3 to 6 months. Spontaneous closure of small vesico-vaginal fistula may be achieved in some cases. Surgical treatment is the gold standard in management of vesico-vaginal fistula. The first attempt for fistula repair carries the best prognosis. لأن لو حاولنا نعمل resurgeries بعد كده بيبقى فيه an amount of fibrosis فبيبقاش فيه vascularity كويسة فرص الهيلينج بتبقى أقل كل مرة عن التانية. Proper post-operative bladder drainage is crucial for success of surgery. Uretero-vaginal fistula. The etiology nearly always occurs as a result of injury to the ureter during gynecologic operations. Symptoms: incomplete urinary incontinence. Inspection by Sims speculum. Small, high, lateral to the cervix. It is small, it is high, it is lateral to the cervix. Investigations: methylene blue test, cystoscopy, ureteric efflux only on one side.